Welcome back. We've been talking about a shift happening in healthcare with changes to licensing rules, opening the doors for thousands of foreign-trained nurses to practice in Canada, and the expansion of private clinics. But here's the big question. Are these changes enough to solve the supply-demand gap at the heart of Canada's healthcare challenges? And do governments really have what it takes to solve the crisis? Erin.
I think they do. They have the ability to make policy. We know that. Whether it's in the best interest of public health care or not. They do have the ability. They also have the financial ability. We need only look to what is happening here with agency nursing, for example. Timmins Hospital, for example, spent $19 million on agency nursing alone last year. William Osler, $16 million. In agency nursing alone. There is a surplus, as we all know, in healthcare spending. So yes, there needs to be investments, certainly in recruitment, as we spoke about earlier, but also in retention. We need to keep our most experienced nurses and healthcare professionals at the bedside so that they can transfer the knowledge, so that there is an investment that patients receive the care that they need. And that's the bottom line.
Dr. Ho, last year we saw a staggering number of emergency departments close their doors for hours, days, even weeks at a time. Should we prepare for a similar situation this summer?
I think, unfortunately, that is the new reality with the staffing shortages that we're seeing across the province and the country. The majority of these ER closures are because we don't have the nurses to staff them. So as we mentioned earlier, and as Erin has been saying, we need to work on retaining our experienced nurses so that we can actually appropriately staff our emergency departments, because closing one emergency department has many ripple effects towards other community emergency departments. It increases the wait times, it increases bed block, and increases the amount of time patients can, the length of time the patient have to wait to be seen before they can be discharged. There are innumerable effects from one single ER closure. So we really need to work on our health and human resource strategy.
Are there any other innovative solutions that we should be looking to fix this system?
Yeah, so I mean, I think I'd like to go back to a few of the other recommendations our members of the public talked about. One, they recognize the importance of upstream investment. So they, compared to other countries, actually, Canada spends less on primary care as a proportion of the total health budget. And they wanted to see more investment in primary care because they recognize if you invest in primary care, it's less likely you're going to have these problems in hospitals and emergency rooms. They wanted to see actually more kind of linkages between primary care and social service agencies and agencies that are able to actually address some of what we call the social determinants of health, housing, employment, education, things that ultimately impact health. And then I would say they definitely wanted to have more information for themselves that would better allow them to advocate and navigate the healthcare system, starting very crucially with access to their own records. I mean, this was a huge point of frustration for so many members of the public. Why is it that they can't access their own records or the records of a loved one that they're caring for? So we need to make changes to move towards that direction.
Dr. Whatley, I see you nodding your head there.
Yeah, I'm really glad that you started to separate out the difference between government capacity. What are governments particularly good at? And how can we play to government's strengths? Versus what is management good at? What are local hospitals and community clinics particularly good at? And then a third aspect, we might want to look at central planning. Some things really are amenable to being planned centrally, like the number of universities we have in the country, I'm assuming, or building a railway from coast to coast. Some things are really amenable to planning. Post offices work well for planning. You can see the work being done and you can see the outcomes. Healthcare is somewhere in the middle. We need government help. We need strong managers. We need some planning. But to put our faith in any one of those buckets while ignoring the others is doomed to fail.
Dr. Ho, I don't mean to put you on the spot here, but are there any examples of other countries that are getting it right?
Well, I mean, I think a lot of proponents of private pay healthcare, private delivery of healthcare will often say that Canada spends on their healthcare budget a significant amount more than other OECD countries per capita. So when they talk about countries like France and Sweden and the UK and New Zealand, and they look to those countries and they say these countries all have a parallel private system. They're doing much better on health outcomes, on equity. But what is often omitted is the second part, which is the fact that when you look at Canada's public-private split in their healthcare spending, we lag behind the OECD average and we lag behind those other countries. So historically, Canada's public-private split has been about 70-30. So for every dollar that Canada spends on healthcare, 70 cents goes towards the public sector and 30 cents goes towards the private sector. That's below the OECD average. That's below those other countries that I listed. And so I think the reason why those countries, despite having a parallel private system, the reason why those countries do better is because they spend more of their healthcare budget on the public sector, and they have more of the healthcare under the umbrella of Medicare. They have dental care, prescription drugs, long-term care, home care, all under the public sector, and that's the reason why they do better.
Bernard, actually, the shift is now 25-75. The latest CI-High data. We're even though we still don't fund eye care and dental care and pharmacare, we are now up to the same breakdown as the OECD countries. And so even more shame on us for spending so much on medical care and really providing nothing for dental services, eye services, appliances, and the rest.
All right, when we come back, we'll get to some of your questions. That's next.